So, good morning, ladies and gentlemen. I'm very glad to welcome you on this ELPA workshop on the occasion of ELPA's 5th birthday. I think we should start now because I'm quite sure it's going to be a little bit more full, but maybe all the people are right now at the railway station trying to get their tickets. As you all know, the treatment of hepatitis B seems to be very easy, but it's still very tricky. We have good doctors, we have willing patients and good treatment options, but what about adherence? I think we are at the beginning of a new area where the communication between the doctor and the patients are more and more important and also improving. I'm going to skip my little presentation because I think many of the speakers want to leave as soon as possible. So I just wanted to inform you about some changes. Professor Niederhau from Oberhausen in Germany is unfortunately not been able to attend this meeting because he is still in Germany. He couldn't fly in yesterday, so Achim Karls from the German EVA Help did overtake his presentation. Also, we wanted to have Professor Forster from London as a second speaker, but we will have Dr. Reiser from Marl in Germany as the first one because he also has to leave. And I would say Achim will then start with a short presentation about adherence.
Thank you very much. Well, why is it important to improve treatment adherence to HPV treatment? I was surprised because the volcano is the reason Professor Niederhau was not here, and so I tried to match his presentation. And, well, the efficient treatments are available for chronic hepatitis B. And the sustained steroid suppression can stop the liver from being damaged and prevent late-stage liver disease. The question is now, can we just sit back and relax about hepatitis B treatment now? Let's look at a patient story. The case report is a 40-year-old man from Turkey who has been working in Germany for at least 21 years. He's aware of the German language, of German behavior, and well educated. His chronic hepatitis B has known for many years, and his treatment is with 0.5 milligrams tenofovir, started in December 2008. At that time, this HBV DNR level was about 36 million international units per milliliter, and his LT was 276 milliliter. So he's HBe antigen positive, the ultrasound is normal, biopsy not done. And HBV DNA became negative in March after, this are 4 months, 2009. And the LT decreased on 2.7 units per liter. Then, in September 2009, patient presented with general weakness and slight jaundice. The HBV DNA was again very high. It's 3.5 million international units. His LT increased up to 721 units, and his bilirubin was 3.2, and the ultrasound was still normal, and he's still HBe antigen positive. So, what happened? There's 3 options for this. So, is it a superinfection, for example, with HCV, HAV, or HDV? Is it a tenofovir resistance, or is it a compliance problem? Well, the HIV, immunoglobulin, HCV, and HDV antibodies are negative. And the patient went on summer vacation to Turkey for 12 weeks. And just took tenofovir tablets with him for only 3 weeks. So, drug holidays for 10 weeks. After re-beginning, the tenofovir always become better after 4 up to 6 weeks. Why we are here? One important message has been repeated over and over again at this EASL meeting. Adherence is key in HPV treatment. It is good that everybody seems to agree about this, but it's not enough to say patients just need to take their pills regularly. So dropout rates, more than 10% each year, clearly shows that this is not working. We need to do more to improve adherence. So it is necessary for us to initiate adherence programs in the future. To make these programs as efficient as possible, we need to combine our efforts across clinics and even national borders. So at this meeting, hematologists from 3 different countries will present their point of view and their experience, and first steps toward adherence programs. And I'd like to introduce now Dr. Reiser from Germany, and he will show us his experience in a new started program. Yeah, so come on stage, and it's now yours.
Thank you very much. Ladies and gentlemen, I would like to present a German project intended to improve adherence in hepatitis B. It's called Beachtung, and it was initiated by die Deutsche Leberhilfe, which is the biggest patient organization for liver diseases in Germany. So, Achim Kautz already showed you why is adherence in HBV so important, why is it so difficult to achieve. We all know that NUS can suppress chronic HBV very effectively. However, long-term therapy is usually needed, and long-term therapy needs long-term discipline. Moreover, since most patients have very mild symptoms or no symptoms at all, direct effects of therapy are rarely perceivable for the patient. Many patients are not very well informed about the disease. We believe, and we have some data, that we are facing a dropout rate of approximately 10% per year. Virus mutations or low adherence can lead to resistant mutations, and resistant mutations can then aggravate the disease, and we are facing very high economic costs. Okay, looking at the natural history of hepatitis B, we hope that with good adherence we will stay here on the left side of the slide and will not go to the right side to the complications of chronic hepatitis B, such as cirrhosis, decompensation of liver disease, or liver transplantation, or even death or cancer. Well, low adherence and resistance development are well-known problems. There was an FDA workshop in 2007 discussing these problems, and also in 2008 an EASL monothematic conference about resistance in HBV, showing that low adherence is correlated with resistance development. However, there's no, at least in Germany, no national work group or studies approaching this problem, so we thought this is a need for attention. And just to give you an idea why we call this project Beachtung, the German word Beachtung is attention, and so we are lucky that we could pull out the B in front of the word for HBV. So the objectives were to form or to start a project intended to improve adherence. We are going to implement these adherence strategies in hospitals as well as in clinics, and also in private practice and patient organizations, and we hope that we will be able to present results and data in future meetings. So the basis of our concept are our patients. We know that HBV patients show a different level of adherence. We know that they are from different cultural backgrounds. They live in different social environments, and they have a very different understanding regarding the necessity of treatment. So, given these facts, we thought we might be able to cluster the patients according to their coping strategies. Basically, we try to stratify the different patient groups. So what we did is, with the help of the German Liver Aid, we interviewed more than 200 HBV patients and analyzed their coping strategies. So we basically grouped them into certain patient types regarding their adherence motivation. So we formed a working group in January of this year. We found a consensus on the basic concept. We presented this project at the German liver meeting in February, and we met again in March to finalize the concept, and we are now in the process of starting Beachtung and to start the documentation and evaluation of the results. So we split up our working group into 3 smaller groups. One team worked on the patient needs, one team worked on the doctor's needs, what do the doctors need to improve adherence, and one smaller group, including myself, will work on the documentation. So with the help of the interviews, we stratified the patients into 5 different coping strategies. This categorization may not be highly scientific, but I'm sure you will recognize the patients shown here. So we have here the therapy tired. This is the patient who sees this therapy as a necessary evil. We have the distracted one, the manager type, who doesn't know if he really took his medication this morning. We have the uninformed who misunderstands the whole thing. He doesn't really know why it is important to take his medicine. And probably the toughest is the uninterested disease denier. So he believes that he's only doing this because his physician thinks this is necessary, but he has no understanding of the whole concept. This is definitely the best one, the motivated health conscious. This patient knows that his therapy guarantees good health. So, and given these types, we thought all these types may need different help and tools to improve adherence. So the therapy tired, for example, he needs motivation. The distracted needs organization, maybe an iPhone app or now an iPad app to remind him of his medication. And these 2 types, the uninformed or the uninterested, they need education and information, maybe even a treatment coach to stay on treatment. So tools and activities to support our patients. We think the patients need a starter kit, giving basic information about HPV, the course of the disease, the transmission, what needs to be done to monitor, and also risk of non-adherence, and tools to stay on treatment, reminder options, even maybe coaching especially by patient advocacy groups or patient organizations. And during treatment, we will provide a patient card to keep track of the results, the transaminases and HPV DNA levels, tips and strategies to support adherence. We're thinking about maybe an email newsletter we can send to our patients to inform them about new developments, additional materials, especially for special patient groups such as women who intend to become pregnant, and also provide workshops and seminars for patients. So tools and activities supporting physicians. Physicians, of course, need tools to perform the questionnaire, to type the patient. They need handout material. They need help probably to involve the families and the social environment, basically creating commitment for HPV therapy. And during therapy, they need help to keep the patient motivated and to keep him in long-term therapy. We think, for example, a waiting room TV might be a neat idea, a recall system, a computer-based recall system to keep track of their patients, or a secure internet expert network to exchange ideas, to upload new publications, or to discuss a difficult indication for treatment. So the documentation, the primary endpoint of the documentation will be the medication per session ratio. I will come to this in a minute. And additional parameters will be documented, the baseline characteristics, dropout rate, reason for dropout. So this is basically not adherence but persistence. And maybe the toughest thing is we are planning to do this study with a control arm. Each arm should have 250 patients, and so the program arm will use the tools I just introduced, but the control arm will provide standard of care, and this, of course, will be difficult not to bias. We think we will have to think about is how we are getting this done. Okay, measuring adherence. Unfortunately, we don't have a tool such as this to give us an exact measure of our patient adherence. We are planning to use the medication per session ratio, which is the number of days applied divided by the numbers of days between the refills, and the example Achim Koch just gave you with a Turkish patient who left Germany for 10 weeks, didn't take his medication, so his number of days supplies was much lower than the number of days between refills. So a ratio of 1.0 would be perfect, but in this case I probably would, the ratio went down to 0.3 or 0.2 probably. In addition, the dropout rate will be documented, which we define as missed 2 visits, and this we call persistence. Okay, and in summary, the aim of this project is to improve adherence in HPV therapy. We formed a working group with physicians working in hospitals and private practice. Our intervention is based on coping strategies, so we are tagging the patients and providing help according to the patient type. We are planning to include a control arm without this specific intervention, and we will measure adherence with a simple and feasible analysis tool, which is the MPR, medication per session ratio. Those are the participants so far. 27 physicians will participate so far, and we hope this number will go up. Thank you very much for your attention.
Yes, thank you very much, Marcus. I think this is a new area, how to think about adherence, to have a very close look to patients and to cluster them in typologists. So now I'm really happy to introduce you another speaker. This is well-known Graham. And yes, I'm very happy that you're on the second time here on this podium for ELPA, and thank you very much, and now have your experience from the UK.
It's a pleasure. Thank you very much indeed. I feel a little bit humbled between my German colleague. I think that's a fantastic initiative you introduced there, and I think that's really terribly important. I do congratulate ELPA for raising what I think is a very understudied, ill-understood topic of adherence, which I think is increasingly going to be important in the way we manage patients with hepatitis B. What I'm going to talk about very briefly is why compliance is important, what we can do to help, and then I'm going to give you a quick rundown of what we do in the UK and illustrate some of our strengths and, I'm afraid, some of our quite significant weaknesses. Why compliance matters, I think, has already been graphically illustrated by your Turkish patient. And the reason compliance matters, of course, is the pills don't work unless you're actually taking them. And not only that, if you take the drugs occasionally, and we've had catastrophes where patients are running out of pills so they take them every other day, which is a guarantee of resistance development in the long term. If we start to get resistance to hepatitis B, there is a real genuine risk that we will start transmitting vaccine-resistant mutations. There's already a lot of concern out in the Far East that some of the limidine-resistant mutations overlap with the surface gene and may start to impact the efficacy of the vaccine. In fact, the WHO, as you know, has already set up a working group to look at that possibility. It remains a possibility at the moment, but I think it's a possibility we can't afford to ignore. So compliance for the patient has critical factors, and compliance for society at large is really very important. So it is a problem. I think the very elegant work you're doing in Germany is the first attempt that I'm aware of to really address this in a scientific fashion, and I do congratulate you on that really worthwhile initiative, and I hope that goes well. But I think there are some simple things that we can try and do to assist in our day-to-day practice. And the first point, of course, is we shouldn't treat patients unless we need to. And using patients and accessing tablets, if they're not absolutely essential, is a huge mistake. We know that hepatitis B moves through different phases. We know in the early E antigen positive phase there's not much liver damage, then there are disease flares with seroconversion, then there are quiet periods, and then once again there's the E negative active phase. I think it's very important that we restrict treatment to those active phases when the virus is doing damage, so we don't use these pills unnecessarily. We have one horror story of a young girl, a 6-year-old girl with E-antigen positive hepatitis B, treated by some idiot with lamivudine for inactive quiescent disease, who's now 7 years old with lamivudine resistance. Didn't need treatment in the first place, her treatment choices are crippled for the future, and her mother, who's very stable on tenofovir, do we worry about her getting a lamivudine resistant mutant from her sibling? Are we going to be worried about the family transmitting lamivudine resistance? It's a real nightmare scenario. So there are real fears about treating people inappropriately, and I do think we should restrict therapy to when it's actually going to benefit. And this, for example, just shows you, we hope, dying. I've had technical problems all meeting, I have to say. This gives you an example of the patient population that we're seeing in East London. What I'm showing you is the number of patients against their ethnicity. And the first thing that's clear is that viral hepatitis, particularly hepatitis B, is heterogeneous in its ethnicity. And most of the patients we see are non-UK born, and most of them, of course, have linguistic issues and linguistic problems. The other important point about this slide is the proportion who have advanced liver disease is relatively small. So the majority of people with hepatitis B will not have active disease-causing virus at the time they present. They need to be monitored, they need to be evaluated, but for many of them, the disease progression is relatively slow. So we need to be cautious about rushing in with unnecessary therapy. And it really is a minority of the patients we see that actually need treatment. And that, of course, poses the issue of patients who are quiet and are then going to flare because they need to be monitored. There's nothing more frustrating to a patient than sitting in the clinic, waiting an hour, seeing a doctor who says, everything's fine, come back in 6 months. And a lot of those patients drift away from services. And we've had horror stories of patients leaving services and coming back 5 years later with liver tumours because they weren't on proper monitoring. So there are issues not just on compliance with drugs, but on compliance with monitoring. So I don't think we should use tablets unless we need to. If we have to treat patients, we need to pick simple, easy regimes. And the blessings that we have with the new drugs are that they really are side effect free. This is picked from the tenofovir study, looking at side effects in one of the pivotal tenofovir slides, and you can see that the discontinuations and the side effect profile of these drugs really are first class. And I think that's a very important message to get out there, that the drugs we're using today really don't have many side effects. A lot of patients take pills and they come in a few weeks later and complain of odd effects. I've got a bit of diarrhea, I've got a bit of a skin rash, I'm itching. We need to make sure patients understand that these are coincidental and not caused by the tablets. Because patients get trivial side effects, they think it's the tablets and they stop. We do need to make patients understand that these tablets cause very few side effects, and before they stop, they should discuss with us the importance of continuing medication. So I do think that initial consultation, getting the right messages across, is absolutely pivotal. So we should not treat unless we need to. If we do need to treat, we should use simple, side effect-free regimes, and we should educate the patient. And I think the key message here is patient information. Patients need to be informed about what this virus does, how this virus behaves, and how important it is to comply with therapy once it's started. So those are the basic principles. What do we do to apply these in day-to-day practice? What we do at the Royal London is really focus on the first consultation. And I think the first consultation for hepatitis B is when you engage with the patient. And I tell patients this is going to be a lifelong relationship. This isn't like marriage where you can give up and divorce. This is a real lifelong commitment. Because you and that patient are going to be together for many years. And I very often draw the diagram of the natural history of hepatitis B, and I show them about quiet periods. And I emphasise how important it is to keep coming even if you're not getting treatment. And I emphasise that when we start treatment, it will be a lifelong commitment to therapy. And I think that information really is critical to keeping patients engaged. And it's not just about the treatment phase, it's about the monitoring phase. And I have to say, I do tend to scare patients a little and talk about how 25% of patients will die from their virus, because people do need to realise that although they feel well, they've still got something potentially very harmful going on. I'm still a great believer in liver biopsy, I'm afraid. I think a liver biopsy has two major goals. The first is it gives you very accurate information on exactly what's going on. And I appreciate patients are reluctant to undergo the procedure, but I still think it gives us new information, and it also helps motivate. I think it does provide a key message to patients. Look, here's a sample of your liver, there is a problem, here's what we need to do. And I think it's important to make clear to patients just how critical that information is, and persuade patients that it's in their best interest to understand what's happening inside so we can make the right judgment. And I say to patients, do you really want me to give you 20 years of drugs without knowing what's happening in your liver? And I think if you phrase it in that way, make patients understand, most patients will agree to the procedure. And we use very simple regimes. We have a simple, rigid monitoring. You start pills, we reattend 4 weeks later to make sure that everything's okay, and then you come back every 3 months. So you can put in your diary that it's every 3 months for the next year. So keep it simple. We do see patients where there are concerns about compliance. If I'm not sure the patient's going to comply, I very often use pegylated interferon, because then we won't get resistance problems and we can monitor the patient and observe treatment. So if there are concerns about compliance, I would often use a directly observed treatment regime and interferon-based treatment. And we've introduced a pharmacist. It's very important that patients have time to discuss their concerns. And most doctors don't have the time. And certainly in my clinic, I'm rushed off my feet with lots of people coming in, and patients on regular review for pills don't get the time they really need. So we've used our pharmacist, who's been trained up in managing patients, and she sees patients and has a half-hour window. So patients can sit down with someone and spend a lot of time talking to them and really understanding their medication. And that provides a bond with the patient and someone who's there with the time to address their concerns. So I think compliance in hepatitis B is understudied. I don't think there have been any proper evaluations of compliance out in the clinical setting, and I think that's a huge drawback to making plans for the future. We really do need some data. I think everyone recognises its importance, but everyone says how important it is, but not many people are acting. And I think you really are to be congratulated for grabbing the nettle of this particular problem. In my view, we need more education. I think education, getting patients involved, getting patients to understand, to interact with us, to tell us what they want from us is going to be absolutely critical. And I do think we need more research, and I'm delighted that the Germans are leading the field here, and I think that sort of research and follow-on studies are really going to be the way forward in telling us how to manage this problem and how to get patients to stay on treatment and protect themselves from harm. Thank you.
Thank you, Graham. It's really interesting, and if you have questions, please ask now, because we have to do that too. So, are there any questions for this topic? No question?
I was just,
okay.
I was just wondering, in monitoring your patients, do you use maybe elastography or some other way of
we don't at the moment.
biopsy?
For hepatitis B, we normally biopsy patients no more than once. We try and biopsy patients pre-treatment, unless there's very clear evidence. I think the fibroscan, etc., are becoming useful in hepatitis B. Our problem is a lot of our patient population are Pakistani Bangladeshi patients, many of whom are a little bit obese, they have a little bit of fatty liver disease. So transient hepatitis doesn't give us the information we need. But I think the point you make about finding patient-friendly ways of assessing what's happening in the liver is really, really important, because the more barriers we break down, the easier it is. And it does worry me that we can't follow patients up as much as we would like. And I think patients, quite rightly, decline to have follow-up biopsies every few years. They're not necessary. It does mean curious. But I think you're right, that we do need to take advantage of the new technology.
Thank you.
Are there any other questions over there?
Professor Graham, this is the most important message I had got from this conference. You complain about non-adherence in Germany and in UK. What about the case in underdeveloped country with misuse of these oral drugs and no time for physicians to talk with the patients? I think that I must counsel the authorities in Egypt, it's my country, to think about an explosion could occur from resistant hepatitis B after some years. Thank you very much.
I think you make a very, very important point, and I think you're absolutely right. In underdeveloped countries where many, I was going to say ill-trained, but that's perhaps unkind, but many inexperienced physicians are handing out lamivudine monotherapy to patients with hepatitis B because it's cheap and it's available. There isn't proper monitoring, there isn't proper compliance assessment, there isn't proper education, and that I think is where we're going to see problems. That's really what's worrying the World Health Organization, who are concerned about the rise of lamivudine resistance throughout Southeast Asia, and there is a suggestion that it's interfering with the vaccine, and they've already got a working party looking at drug-associated vaccine-resistant mutations, and I think that that is a major concern. I don't have an easy solution, I'm afraid. I think it's going to be very, very important to educate. Slightly controversially, I am beginning to wonder if we shouldn't start to put restrictions on the use of lamivudine and shouldn't actually start to think about withdrawing it from the market. Because I do think lamivudine monotherapy in today's world is perhaps doing more harm than good. And I've used lamivudine for many years. I think it's been a great drug. I think a lot of patients are alive because of it. But it does worry me that there is extensive monotherapy use in unmonitored conditions, and 70% of those patients are going to run into trouble. And those patients are going to transmit resistant mutations. So slightly controversial, and I begin to wonder if we shouldn't be a bit more aggressive. I'd be interested in colleagues. Sometimes I've been sitting smiling there. That's something you'd be prepared to consider. Yeah. And I think it's an area we need to start looking at ways of stopping harm to the population.
So, any other questions?
Thank you very much.
Thank you very much.
Thank you.
Okay. So, and now I'm very happy to introduce Stanislav Pohl, and I heard you're supposed to have a Heroes program in France. Is it Heroes? It was presented yesterday, so I hope you saw it. It's today. It's today. Can you back with this stuff? Stanislav Pohl.
Okay, thank you very much. Thank you, Nadine, for the invitation of ELPA, and I will give you our experience, our French experience in adherence to anti-HBV analogues. It's work which has been conducted by my collaborator Philippe Senu, who is there and will present the poster today. So, of course, you know that with the new second generation analogues with high antiviral potency and high genetic barrier, the main problem is not the efficacy of the treatment, but the long-term safety, and also, of course, the efficacy which is related to tolerance and adherence. So, I would like to answer to this different question: the frequency of poor adherence, the consequences, the measure of adherence, the predictors, and how to improve adherence. So we heard a lot of very important things today, but I would like just to emphasize the frequency of poor compliance. This is well known in the clinical study of the field of liver disease, and as you can see, the mean adherence rate in all this extrahepatic disease range from 50 to 80%. So to make it simple, around 1/3 of patients are not fully adherent. This has been well analyzed in the HIV field with the antiretrovirals, and in this study, which evaluate fair adherence as corresponding to an intake of more than 80% of the treatment, you may observe that only 55% of patients in North America and 77% in Sub-Saharan Africa had a good adherence. So clearly there is some room for patient and physician education in the information of non-adherence and its risk, but Marcus and Graham have already discussed this point. A similar situation than the treatment of HBV is arterial hypertension with once daily treatment. And as you can observe in this huge study, around 50% of the patients are not taking the treatment after 1 year. Either it's a minority because they do not adhere to the treatment project at the beginning, 2%, or because they discontinue during the treatment, so half of them for the first year. And you may observe that in the other half of patients who are taking the treatment, 43% of them discontinued at least 3 days during the period. So we aim to evaluate the compliance to analogs in our clinical practice and its relation to virological efficacy and the affecting factors of adherence. So the inclusion criteria were very simple, corresponding to our daily practice. It was HBsAg positive patients who were treated by analogs since at least 3 months, undergoing regular follow-up in our unit with a blood sample, of course, ultrasonography follow-up of extensive fibrosis or cirrhosis, and we have excluded patients with comorbidity, namely co-infection, HIV, of course HDV or HCV infection, and also transplant recipients patients in order to avoid some confounding variables either in adherence but also in the safety of this long-term treatment. To measure adherence, we have used an auto-questionnaire which is completely derived from HIV field. This is this auto-questionnaire. It's very simple to fulfill. When the patient is waiting for the clinic, it's really easy to fill it. You see that there are 4 questions and visual analogic scale which is helpful, and we ask the patient to consider what is his adherence rate on a scale from 0 to 10. The patients were classified into 3 categories according to adherence, and this is adherence classification. Of course, patients who are taking all the drugs were considered as totally adherent with a visual analogic scale score of 10. The patients who take more than 80% of the treatment with a scale from 8.1 to 9.9 were considered as moderately adherent. And finally, those patients with less than 8 on the scale were considered as non-adherent. We have some usual clinical data which were fulfilled in the database with, of course, the kind of treatment, the switch of treatment, the add-on or switch policy, the clinical history of the patients, and all the biochemical variables. So these are the baseline characteristics of the patient when they begin the inclusion in the analog adherence program. You see that it's a mean age of 60 years with 55% of male. As usual in France, 1/3 of them were HBe positive. And you may note, but of course it's reflect of the higher potency of the analogs, that 83% of them had undetectability of HBV DNA. And finally, almost 50% of those patients had significant fibrosis or cirrhosis. And you may observe that most of them, as Graham emphasized, underwent a liver biopsy, at least at the beginning of their history, in order to better define the place of the antiviral treatment. So these are the different duration of the treatment. Of course, you can observe that most of those patients were treated by analogs since around 5 years, and more than half of them have already undergo a change in the treatment, of course in relation with the inefficacy of the previous treatment. This is a summary of the treatments which have been taken. Minority of the patients were treated by first-generation drug in single therapy, lamivudine or adefovir. Of course, this reflects that those patients either had add-on therapy with time or switch in relation with insufficient viral suppression. So around half of patients were treated by single therapy and half of patients were treated by a combination either of first-generation drug or using first and second-generation drug. An important point is that in our experience, the treatments themselves, first or second generation, single or combo, did not impact in the adherence rate. So these are the results of the questionnaire, and you may observe that 1/3 of patients are, just like in the other fields, were not completely adherent. 7% of the patients were considered as non-adherent, and 32% of the patients were considered as moderately adherent. So what are the consequences of poor adherence? And this is the result of our multivariate analysis, which indicated that clearly non-adherence claims is associated with poor antiviral efficacy. It's an evidence. It was the first slide of Graham indicating that to be efficient, the drug has to be taken. And also a baseline and a change in analog treatment were associated with undetectability. It's simple because when patients were not fully controlled by the treatment, we perform either add-on or a switch policy. How to measure adherence? There are different ways to do that. Indirect method, and it's what we have done because it's very easy. The point is that, of course, we have to ask the good question, not only a simple question as do you take your treatment, because all the patients are taking their treatment, but more to detail the number of skip dose, and usually by using the simple auto questionnaire that we have used and derived from the HIV field, it's really simple. It's nevertheless more simple than the direct methods. Direct observation, of course, is impossible. Blood monitoring is costly and not necessarily relevant, as well as a measure of the virological effect. So there are some methods. Of course, we have to validate this different method, but the auto questionnaire is a simple and reproducible method. What are the predictors of adherence in our experience? And as I told you, finally the treatment itself, single or combination treatment, is not clearly associated with adherence or non-adherence. The two main points which were associated with adherence were the number of patients followed by the physician, namely the experience of the physician, and second, the duration of the treatment for more than 36 months. This is illustrated on these histograms, and of course, I think that this education of the physician has a positive impact on adherence and then on the treatment efficacy. It has been already reported that the duration of the treatment also impacts the adherence, and of course this is the experience of the treatment, probably the reinforcement of the education in the relation between the physician and the patient, which explain this positive impact of the duration of the treatment. How to improve adherence? We heard with Marcus a lot of very interesting ways to do that. There is a complex interplay between the actors of adherence, the patient, the physician, the disease, and the treatment. Concerning the patient, of course, we have to control, for example, psychiatric troubles and other social or economical limits to care in those patients before to begin the treatment. It's true for all the disease. And we have to control the missed appointment, which usually corresponds to poor adherence. Of course, we have to convince by fair information the patient of the benefit associated with the therapy. And you know that all the studies now with the first generation or the second generation analogs clearly indicate that viral suppression is associated with firstly a decrease in echo inflammation, then stabilization of fibrosis, which result in fibrosis reversal. And you know that in the extended follow-up of a control patient with cirrhosis, up to 40 to 50% of cirrhotic patients may exhibit cirrhosis reversal. So clearly there is a benefit. The first study of LIO, a control study, indicated that there was, after 3 years of treatment with lamivudine, which is of course not the best viral suppressor, there was a 50% decrease in the rate of progression of the liver disease and in the rate of hepatocellular carcinoma. So even if it's an asymptomatic disease in most of patients, the benefit is there, and we have a lot of material to convince the patient that adherence and viral suppression are necessary to reduce the risk of liver-related complication. And of course, this will help in the investment of the patient in his disease. Concerning the side effects and the treatment complexity, we have no problem for HBV. It's mainly once daily intake of one treatment, so the same situation that I have introduced with hypertension. So really I think that there is no problem other than the conviction of the patient and the physician. We have to recall, I already said that, but really it's important that it's not because the disease is asymptomatic that it's not associated with high risk of morbidity and mortality. And this necessitates compliance and regular follow-up in order to anticipate the risk of resistance and the risk of viral reactivation in non-adherent patients, as it has been presented in the introduction. And finally, clearly, there is a poor relationship between the physician and the patient. We have to recommend modification of the relation or to change of physician. So in conclusion, adherence appears as an independent factor associated with viral suppression during anti-HBV analog treatment. Short treatment duration and physicians following few treated patients are independent factors associated with low adherence. And we consider, as the previous speakers, that a systematic evaluation of adherence using, for example, but there are other methods, self-report and clinical practice should be encouraged, as well as therapeutic education of patients and physicians in order to maintain for the long term a complete viral suppression, which allow not a recovery of the viral infection, but in most of patients a recovery of the liver disease. So I thank you for your invitation and for your attention.
So are there any questions? Stanislav.
Perillo from USA, and I was wondering if you had enough patients in your retrospective cohort who had family members with serious complications of hepatitis B who demonstrated a different adherence pattern to your general group. Because to me, I think you hit the nail on the head about education. It's an asymptomatic condition. The drugs are costly in our country, and that impacts on it as well. So we impress them with the future complications, and it seems to me that people are more receptive when they've had an uncle who's had a hepatocellular carcinoma. Did you have enough